Thank you all for joining us for this Our Street and Safer from Harm hosted virtual panel on barriers to addressing substance use in pregnancy, the view from Virginia. Important topic, close to my heart for sure. And we're here today. I'll let folks introduce themselves in just a minute, but to talk about a topic that is often misunderstood and misrepresented. So that's opioid use in pregnancy. And so first want to set the foundation by saying that our goal is to be driven by the evidence to ensure that in difficult situations, we have healthy babies, healthy moms, and healthy, safe families, all of which matter a lot and are interconnected and intertwined. So today we want to learn about and focus on what this looks like in the state of Virginia. It's about one of about 23 states that still penalize and punish women solely for taking prescribed legal gold standard medications to treat their opioid use disorder while they're pregnant. In other words, Virginia's laws treat life-saving medications for babies and moms the same as illicit drug use. We're going to talk about that today, as well as the broader picture of what's happening in the state. And really grateful to be joined by two Virginians who've devoted their careers to caring for mothers and infants impacted by opioid use and by the systems and policies that put them at greater risk, as well as my wonderful colleague, Stacey McKenna. Before we start, I'll just note that, as always, in all of our Street conversations, we welcome productive differences and dialogue, as long as they're shared respectfully. So we do have a Q&A, and we'll be moderating and going through that with whatever time we have. We could talk probably for hours on this, but we'll try to leave some room for questions. And just will note that this, kind of respectful tone is especially important when we have people who are coming to us from a place of lived experience, which is the case in our panel today. So I'm sure that we can count on folks to be respectful of these experiences and the work it takes to share them, and we are especially grateful for that. So I'll pause there and just say I'd love it if each of you would briefly introduce yourself. Kalie, would you mind going first?
Yeah, I'm Kalie Owen. I am a licensed clinical social worker and certified substance abuse counselor. I live in Richmond, Virginia. I work for a program called OB Motivate at VCU Health. We are a multidisciplinary, co-located treatment program, and we treat pregnant and postpartum women with substance use disorders. I also previously worked at a methadone clinic in Richmond, Virginia. And prior to that, I was a case manager with the Richmond CASA, Court Appointed Special Advocate. So I also have that experience in the juvenile and domestic relations courts. And before that, in a previous life, I was also a doula. So my work now brings that love of pregnancy, pregnant women, and also the substance use as well.
Thank you so much. What an incredible suite of things to bring to the table on this important work. Julie, would you tell us a little bit about yourself?
Absolutely. My name is Julie Peck. I am a CPRS or Certified Peer Recovery Specialist. I'm also a birth and bereavement doula. I work at Virginia Tech on the HCCD study, better known as Healthy Brain and Child Development, working with pregnant women, some of those with opioid use disorder or substance use disorder, and their children. Um, Previously, I worked in domestic violence and SA as well with women going through that. Um, yeah, and so much more. I won't get into all that, but thank you for having me.
Thanks. And of course, Stacey.
Yeah, thanks, Jessica. Thanks. I feel super humbled to be on this panel with these two amazing folks who are bringing such a different perspective. So my background, I am a senior fellow in our integrated harm reduction department and lead our work on harm reduction for opioids and other illicit drugs. Before joining R Street, I worked as an independent scholar and journalist. And then before that, I was a researcher studying substance use. So most of my career, I have studied substance use to some degree. And it kind of started from in my own experience as a person who used methamphetamine for a long time. And then that led to years of ethnographic research with folks who are actively using, mostly women. And so this particular topic, when you're working with women who use substances, you start to just see what a big deal it is when women struggle to have access to care, whether that's treatment or whether that's general care for their own health and well-being during and following pregnancy. So I'm just super honored to be part of this panel and excited to have this conversation today.
Thanks, Stacey. And once you all get talking, I'll drop some links, resources for folks, including some of your scholarship, Stacey, on the issue. And we'll follow up afterwards too, if Kalie and Julie have additional resources to share. Okay, first, just baseline, because there's so much misunderstanding about this topic. I thought let's together clarify some baseline evidence. We know, of course, that untreated opioid use disorder in pregnancy poses risks to mothers and fetus alike. Well, not alike, but to both parties. Addressing that effectively and safely is rife with misunderstanding, and that misunderstanding and the stigma that comes from it can actually lead to policies and behaviors and systems that create more harm, unintended. Stacey, could you briefly tell us what the evidence tells us about what is best practice for people who have opioid use disorder and become pregnant?
Yeah, for sure. So what we know is that the medical best practice, the thing that is going to reduce everything from overdose risk for the mom, which is obviously harmful to both mom and the fetus. But it also improves birth outcomes, right? And even long-term outcomes for raising that child. The thing that we see that is the most effective is access to medications for opioid use disorder. So especially buprenorphine and methadone, and working with a provider to decide what is the most appropriate for that particular family. These medications are incredibly safe. They're FDA approved. They're safe for mom. They're safe for the fetus. They're safe for mom to continue taking and recommended for the mom to continue taking after birth. And they are really hands down best practice. Not only do they improve those outcomes, but they improve engagement with the healthcare system and trust in the healthcare system.
Thank you. Kalie and Julie, how do you see that in your practices, in your daily life working with folks? What do you see? Do you see positive outcomes of access to these medications? What do you see for those who aren't able to or don't, for whatever reason, take these medications? Would love to hear from you a little bit there.
Yeah, I'll say that pregnancy can be a great motivator for patients. Substance use disorders are chronic conditions that don't disappear when a person becomes pregnant, just like high blood pressure or diabetes don't magically resolve when a person becomes pregnant. So it's just another condition that can be treated. We have a lot of patients who their first time that they feel really motivated to engage with either the healthcare system in general or substance use in general is when they become pregnant. So it can be a wonderful time to intervene because people are going to appointments, and when they become comfortable with their providers, they can open up and really start accessing that treatment. What we find is when the barriers are too high for people or there are too many barriers, that's when it can become a challenge for them to start to engage in treatment, such as, at methadone clinics, you need an ID and you need to be able to get there every single day within this very short time period, often 5:30 in the morning until 10 a.m. And that's not always accessible to people. So while it's a good time for people to start treatment, there are also plenty of barriers that can make it hard for them to engage.
Yeah, and I'll follow with just want to start off by saying that I am someone with lived experience. I have 19 and a half years in recovery, so I was in MAT treatment myself for opioid use disorder. But it gives individuals quite literally an opportunity to start over, which is important, having all that trauma, that extra baggage packed on. By getting treatments, they're able to stay stable, and have reliable resources, which is extremely important when you're starting out in recovery and in treatment. Um, it allows them to build relationships and rapport with peers, counselors, and many others that they work with over time. But it also allows them the chance to mend broken relationships with their own families which is extremely important. Um, it allows them, once they have mended those and maybe addressed some of the issues that they had when they were in active use, to take some of that heavy weight off of them so they can feel like, it's okay to move forward. But it gives them a very much needed time to heal, most importantly, and to be able to trust again, which is huge. Um, I have a participant a person that I've worked with in the past, and she had started out kind of bouncing around. She had gotten out of from being incarcerated, and had nowhere to go. Her family was not reliable, and they were kind of against her because she had started into treatment, or because she was actively using at the time. Let me back up there. I'm sorry. And she was bouncing around from one place to the next. So after I was able to get in touch with her and start working with her and to get her into treatment, and, with just a very short time working with her, she was able to actually start getting her GED. And over time, after she gave birth to her child, having her own place again, and was able to really thrive and be a good mother, be a wonderful mother. You know,
So,
um,
yeah,
sorry.
go ahead.
Yeah.
No, go ahead, please.
I just wanted to briefly say also on those that do not, they have a harder time with retaining custody of their children, which we'll get into later, I'm sure. Um, but they're also fighting those traumas alone. So they're terrified of reaching out. Um, and they don't have any consistency, in any type of support. And it leads to real issues within the pregnancy and their mental health. Unfortunately, a lot of our pregnant population this way is taken off of their mental health medications, which leads to or can lead to heavier drug use.
So even beyond medications for opioid use disorder, you've got folks that you support who are taking medication for anxiety or depression, and when they become pregnant, their doctors stop prescribing, or what happens?
Yes. So they're the doctors that they are seeing for their mental health, kind of just drop drop them at that point and tell them to come back after they've given birth. It's unfortunate. Many have been told, that's not the way to go about things, but
And these are medications that are deemed safe for use in
yes,
pregnancy.
yes. And if they are not, it's always an alternative out there that they could be, switched
Mhm.
over to as well. So it's very unfortunate situation.
Yeah. Having been through the ringer of pregnancy and motherhood myself twice, moms need all the support they can get for stable mental health. Okay, so let's talk about policy and the policy landscape that kind of sits behind all of this. Stacey, I'll drop it into the chat, but can you talk a little bit about what the policy landscape is in Virginia right now regarding pregnant women who are medically advised to take medication for opioid use disorder?
Yeah, for sure. Before I do that, I just want to jump in really quick on something that Julie mentioned that I think is so important, right? Which is the extent to which, like when moms lose their child or risk losing their child because of these issues, not only does this end up like actively harming the family unit, right? Like we know that there are traumas and problems for the child in most of these cases in the separation. And we also know that it derails recovery for the mom, right? So parents do a lot better in recovery when they have that extra motivation of their child and caring for their child. And so it's this really deeply intertwined relationship where we're not our priority, of course, is keeping kids and families safe in these situations, but removing supports and discouraging engagement with supportive systems is actively causing harm everybody in the everybody involved. And I just think that's something we can't forget as we kind of get into the weeds around a lot of this, which is where the policy piece does come into play, right? Because so current policy in Virginia does what about half of states do, which is it says that mandatory reporters, which includes healthcare providers, should be reporting for children that are, the language is affected by controlled substance use during pregnancy, right? And use of controlled substances, right? Controlled substances includes illegal drugs. It also includes drugs that are prescribed. And it doesn't offer any clarity around that. It actually specifically does nod to withdrawal symptoms, right? So a child born, a baby, an infant born who is experiencing withdrawals from opioids that were prescribed maybe for pain to mom, maybe for opioid use disorder, right? There's a variety of reasons that she could be prescribed those opioids. The infant might experience withdrawal upon birth. Infant withdrawal symptoms are really, really well managed, mostly by being with mom, actually, like skin to skin contact and being able to stay in continuous contact as much as possible with the mother has actually been shown to be a more effective response to infants in withdrawal than medical intervention. So we like the push to report and separate very early is problematic. And so what happens in this landscape from a policy perspective is many mandatory reporters may feel that any substance, like even prescribed substance use of substances as prescribed, constitutes abuse or neglect because of the way it looks in code, depending on what their hospital's resulting policy looks like, depending on what their training has looked like, depending on their own experiences, biases, right? Because healthcare providers are humans too, and they come to all of this with their own sense of that. And so it really leaves it open for mandatory reporters to actually feel pressured that they have to report if a child is born to a woman who has been taking these prescribed medications.
Sorry, I'm trying to come off mute here. Apologize. Thank you, Stacey. So for our panelists, kind of responding to that and in that context, how have you seen this policy landscape in action with patients? Have you seen it enforced, or if folks know about it, are they kind of preemptively reacting to that reality? What are you seeing out there?
So this policy is really front and center in the care that our patients are receiving. Our patients come to us pregnant, and many of them are taking either methadone or Suboxone, whether they're on it already or they're coming to us to kind of talk about their options and get started on a medication. And me as a social worker, part of my role is to educate patients about the mandated reporting laws in Virginia because it's a factor with whether or not they want to start the Suboxone or whether they want to start methadone, knowing that by taking this prescribed, safe, effective, life-saving medication, that is going to result in a mandated CPS report postpartum. So it's something that we bring up the very first time we meet patients throughout their care, process that with them, discuss that with them. A lot of patients are really nervous and hesitant to start these medications because they don't want that scrutiny. And it's really important to know, like Stacey was saying, like withdraw for a baby, um, it is common. It is temporary. It's very well managed. And whether or not a baby is going to have withdrawal symptoms largely is a result of genetics. Just like I take a medication and I feel fine on it, somebody else takes it and it makes them feel weird. That's based on our different bodies and our different genetics. And it does not mean that a patient was misusing their medication. It doesn't mean that that medication is harmful. It's just the way that that baby exists. So when we think about if a baby's been affected by a medication, that doesn't really help determine whether or not this family is safe. It doesn't really have any impact on if this patient has been using illicit substances or not. It's not really a good barometer to determine whether or not a CPS case should be opened. And there are lots of other medications that aren't controlled medications that can also cause withdrawal symptoms for babies that aren't having this further scrutiny. So it can be really scary for patients, and they can be made to feel like they're taking a medication, but they're being punished for it. And some states have reporting where there are two paths of reporting where if a baby has been exposed to, let's say, Suboxone or methadone, that can be reported because there's like a federal mandate where that those numbers need to be tracked. But it doesn't mean that it needs to be reported to CPS. It doesn't mean that anybody is suspecting that there's abuse or neglect taking place. Unfortunately, Virginia doesn't have those two paths. We only have the one path for reporting. So that can cause a lot of fear and patients feeling like their doctors are just gonna, turn over all their information to CPS, and it makes this very like mistrustful relationship with healthcare providers sometimes.
Yeah, I agree with you totally 100%. So like you, Stacey said earlier, some of these laws that were put in place are, quite literally harmful to this population. It breaks down the doctor-patient confidentiality dynamic, um, which is very unfair on both sides of the spectrum for the physician and for the patient. So, they're not able to trust that person anymore. And like some of you already stated, so much fear is brought up in that issue, and they already have so many and other individuals they're having to deal with, and knowing that that's going to be reported, and it's kind of like, well, you've turned your back on me, you know. You're supposed to be here to support me through my pregnancy, but you've straight up turned your back on me, and I don't trust you anymore. And it really harms retention rates within the OBGYN spectrum. Um, it's a very unfortunate situation that I think could be remedied rather easily if done in the proper ways. But it's unfortunately leads to some individuals not coming in at all. They might come in for their first visit and maybe show up for their ultrasound, if that, and then not show back up until birth. And I have seen some that have just absolutely avoided going in all the way around, because they're so fearful of, being reported and what might happen, and they don't want to lose their children.
I think it's something that the kind of stereotypes and sort of knee-jerk reactions forget, right? Is that these are moms who love their children, and if they're, looking forward to and they're pregnant and looking forward to having a baby, they're going to love that baby. And so staying away from medical care is in that moment a rational decision if you feel like you may have your baby taken from you forever once your baby's born. Um, and so staying away from that care has all kinds of health impacts for any pregnant woman and fetus, not getting that prenatal care, not, checking for hypertension, all the things they check us for when we're pregnant. But then on top of that, not staying away from care and therefore not getting care for chaotic drug use or for opioid use disorder. And then that jeopardizes mom and fetus. So that's not intentional. It sounds like you're saying on the part of the mom, there's just so much culture of fear created by these policies. Um, Sorry, I apologize. You maybe already said this, Kaylee. I'm taking notes and trying to keep track. But when you and I talked a month or two ago, you were telling me that you've worked with women who decide to taper off their medication. Did you say this already? Sorry.
Yeah, some women believe that, oh, if I test negative at the time of delivery, then CPS won't get involved. But if they've taken an illicit substance or these medications at any point during pregnancy, it's really supposed to be reported. So even if they taper off and are testing negative at the time of delivery, there can still be a report made.
Hmm.
And baby can be testing positive, especially if the hospital system tests the meconium, which is that first poop that baby has. So
Hmm.
baby's not getting rid of waste the whole time they're in the uterus. So that meconium has can have be testing positive for substances that haven't been used for weeks or months. So that, some jurisdictions, CPS jurisdictions, are using that information against families, even though a person may be in a very different place than they were at the beginning of pregnancy before they maybe even knew that they were pregnant. So
And
there's
of
just
course,
a
the tapering off is not safe, right? That's not recommended.
It is absolutely not medically recommended. When you come off of those medications, you're at higher risk of relapse. So a return to use, and when you use medications from the street, they could have anything in them. People are using cocaine, but it has fentanyl in it. They're using fentanyl, but it has xylazine in it. All kinds of things. You're at risk of communicable diseases, Hep C, syphilis, HIV, if you have a return to use, obviously overdose. If you're off of your medications and you're using again, there's a huge risk of overdose, and overdose is one of the leading causes of, maternal death during pregnancy. And postpartum, even more so, that first year postpartum, they have a higher risk of perinatal mood and anxiety disorders, and not being on a stable medication can be really, really harmful for patients and have a lot of return to use and overdose deaths in that first year postpartum too.
I just want to pause and say that this is so hard and we appreciate you talking about it and even more doing the work every day. Um, Julie, you mentioned to me last time we talked about placenta test. I didn't know. I just learned something new about meconium testing. Will you talk about placenta testing as well?
Yeah, absolutely. So unfortunately, it's also kind of the same thing as what she was describing with the meconium. Um, so at birth, if they decide to take the placenta and test, it can go back so far within pregnancy. And it might show up that mom has used prior to her even having knowledge that she was pregnant, unfortunately. Um, I would like to share a story with you that I have recently experienced with a mother that unfortunately had this exact thing happen to her, um, which led to her child being removed. So, because she was on MAT treatment, first time mom, so excited. She was doing great, doing everything that she was supposed to be doing. Um, I get a phone call. She is irate, crying all over the place. Don't know what to do. And she's telling me they're saying I tested positive for this, but it's not possible. So then she later learned it was from placenta. They had used that and come back with, oh, you were positive for X, Y, and Z. And she tried to tell them that was prior to use, prior to her being pregnant. Um, they didn't really care, unfortunately. And so then she was fighting back and forth. Her husband had nothing in his system. They were kind of told that you know, he wasn't there enough, which was odd, in my opinion, that he should have been present more and that, baby could not go home with him either. They brought other family members in, grandfather, they told him he was too old, which is just, I don't even know what to say about that one. And sister-in-law was brought in or tried to come in, and they were told that, you have 30 minutes to get here. If you're not here within 30 minutes, you might as well not show up. And unfortunately, we're in a very rural area and a perinatal desert. It takes a good 45 minutes or more to get to our facilities. So she's told them that's impossible. I can't make it in 30 minutes, and you know that. So it led to the child removal.
And this is, I mean, this sort of segues into, I wanted to ask you all, in conversations with both of you, have heard about inconsistencies in how social workers and CPS workers and others treat women taking medications for opioid use disorder, or maybe with I have come out of use, but the placenta is testing positive, or meconium is testing positive, doing, what people would say, you're doing things the right way and you're trying and you're, moving forward into better wellness, and still facing these gut-wrenching situations. What do you all see, in Kalie, you're in, urban area, right? But you work with folks outside of Richmond as well. Julie, you're in a quite rural area. Um, what do you see in how is there consistency in how these social workers and state workers treat these cases? Are they trained in and versed in addiction science? And what are the, kind of best practices, and evidence-based practices to support moms and developing fetuses?
Um, the CPS jurisdictions are wildly different just from you cross a patient 2 miles, living 2 miles away from another patient are going to have completely different outcomes from a CPS standpoint, even if they have the same circumstances in their life. I'm in Richmond City. We have many surrounding counties, Chesterfield, Henrico, Goochland. But then I also have a lot of patients who drive from very far away, Winchester, Mecklenburg, South Boston, which is almost North Carolina, are coming to us because they can't find providers in their area, which I know we'll probably get into in a little bit. But when I'm discussing CPS with people, I ask them where they live because that's going to have a huge determining factor about what their CPS case looks like. So some of the jurisdictions are very, very strict. Patients taking Suboxone has only taken Suboxone, no illicit use, but baby has withdrawal symptoms. There's going to be a case open in certain jurisdictions. Um, I just had a patient last week in a specific CPS jurisdiction, had active cocaine use throughout pregnancy up until delivery. Mom's positive for cocaine, baby's positive for cocaine, and CPS did not open a case. And that wasn't surprising based on where she lived. But if she lived 2 miles over and was in another jurisdiction, that baby probably wouldn't have even gone home with her. Um, and I'm not, it's here or there who needs more support. I don't think that CPS needs to necessarily be involved with all those cases. This patient was engaged in treatment. She was consistently coming to appointments. She had counseling. Um, I'm not arguing whether or not CPS should have been involved, but the fact that it would have been wildly different if she was in a different jurisdiction is just very striking, and it can be heartbreaking for patients who are like, well, my friend CPS didn't get involved, and now why do I need a supervisor? And it's really hard to tell them. It's really just based on their zip code and where they're living. Um, I'll also say that there's not a lot of education for some CPS workers. Some are fantastic and they've gone and gotten their own education. I've spoken at the Virginia DSS, conferences trying to educate, but there can be a lot of misinformation and CPS workers saying a patient's on too high of a dose of Suboxone or methadone, really without any scientific basis in that, or, you know, coming from like a non-medical provider, or saying, well, why do they need to still be on this medicine? Shouldn't they be off of it by now? They've been on it too long, and having to kind of re-educate these caseworkers on, this is a chronic condition. They never need to get off these medications ever if they don't want to. There is no such thing as too long. So there's a lot of education. And if patients sign a release of information and want me to speak with their CPS workers directly, that's part of my role, is to kind of provide that education for their workers and answer any questions they have about like addiction and addiction treatment.
So what does what does an investigation look like? And I'm sure it looks very different. Every single one has its own flavor, but I wondered if you could help us understand what that looks like and the extent to which investigations and folks knowing about other people in their networks, having been investigated might create a deterrent even when women are progressing and working on their substance use and trying to move toward that place of more wellness. Like, what does it look like to be investigated? While, let's say, for example, because the universe is so big and we only have an hour, when you are taking prescribed medication for opioid use disorder, for example.
Yeah, so the social worker postpartum will call CPS. They'll report mom's drug screens, baby's drug screens, and if CPS decides to open an investigation, they'll come to the hospital before baby's discharged. They'll interview mom, are you in treatment? Did you get prenatal care? What's going on? Excuse me. Also get like drug screens and then determine whether or not they believe it's safe for baby to go home. Sometimes they'll drug screen other people in the household as well. Pardon, I'm getting over a cold. Um, and sometimes they'll request that there's a supervisor 24/7 who can be present anytime with baby as well.
What do you see, Julie?
Yeah, so absolutely everything she just said is just like right on par with the same that I see. Um, but I do want to say that, of course, speaking on CPS workers, I can't say one way or the other on each individual worker, of course, because there are some amazing workers. But from my personal experience, like the story I mentioned earlier with the lady with the placenta, that's the case. They came to the hospital, removed her child, discharged her immediately. She was not allowed to come back. Um, Her goal to breastfeed, she was not allowed to do that either. Even though after she was discharged, she went immediately to her primary care physician and to the MAT treatment facility, and she was tested multiple times in multiple different ways, and they all come back negative. And when she reported this, she spoke with a worker, and they said, "Well, we'll see. Maybe she gets to the hospital after they told her, yeah, it'd be okay." Um, and then it's, well, no, you can't, because the higher up said, no, 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 that's a no-no. We can't have you do that. So just a lot of trauma, just a lot of emotional trauma there. Um, but there needs to be more training in some areas. Um, like I said, from my personal experience in cases that I've worked with, um, things like training on MAT treatment, OUD, during pregnancy, trauma-informed care, unconscious bias training could be beneficial, very beneficial, because unfortunately, sometimes that happens. It's their own bias that might, trigger whatever. Um, Yeah, I feel like there definitely could be some better overall and some more consistency. Like, you were saying, it is different from county to county, unfortunately. And it's quite unfair, and the consistency is very much needed all the way across the state. Um, yeah, I think that's all I
Yeah.
really have on that. She covered most of it.
Like I said, we could probably talk for hours. Just keeping my eye on the time, but I did want to ask Stacey, we've heard from Kalie and Julie a bit about the kind of extra or unique challenges of rural areas. And, in your research, you've looked at rural access to care in different ways, and just wondering if you could talk about what those barriers might look like on a population level from your research.
Yeah, so thinking about the barriers, right? Like we know that medications for opioid use disorder are just an awful lot harder to access in rural areas than more dense areas. Um, Oftentimes this means there are fewer opioid treatment programs, right? That are the only way you can get methadone, Or if they have one, maybe they don't have anyone who has ever worked with a person who's pregnant, or they're not comfortable doing so. We, with buprenorphine, which is much easier to access in general because it can be prescribed by a number of healthcare providers. But in rural areas, we see that like pharmacies are less likely to dispense it. They're more worried about a variety of issues. Um, and if you have to go, so like in some rural areas, you might have to do something like the closest pharmacy to you might actually be across state lines. And if you have a prescription from another state for this medication and you go to the pharmacy to get it, the pharmacist is then like, no, this is drug seeking behavior, as opposed to someone just trying to fill a prescription, right? So access can be really, really challenging in these rural areas. Um, and then pile on top of it some of the things that folks have already mentioned, which is that often perinatal care is also really hard to access in these areas. So I actually know in Virginia, like some of the Virginia harm reduction organizations have actually, like, one of the things they have done is just make it a mission to actively serve as connectors and make sure that their participants do have that access to perinatal care, to general health care, to pediatric care, if that's what it takes. And when I've talked to some of these folks, I mean, when I say ensure access, I mean like show up at the door and provide a ride, like a 2-hour drive to someone to get them to that appointment because they don't have another way. And so they've just like really stepped in to fill the gap. And we see this a lot in rural communities where there's a lot more integration of care because there can't not be. If we don't have these harm reduction orgs stepping in to fill the gaps, if we don't have programs like Kalie's and Julie's that are like helping to be connectors between these different pieces of healthcare systems, they can be really they can be disconnected in a way that doesn't end up serving the patient really at all. I hope that helped answer.
Yes, for sure. Thank you. Um, so let's talk then about tools and strategies to keep moms safer, to keep developing fetus safer and healthier, to keep babies once born safer and families together whenever possible and optimal for everybody involved. What works? What needs improvement more broadly to help these very interconnected folks be well and safe. So, first of all, I'll say not everyone seems to agree that keeping family safety safely together is an optimal goal. That doesn't seem to be sort of first instinct for some folks. So, for all three of you, sort of round robin. I mean, we talked about this a bit, but if you want to add anything, impacts good or bad that you've seen when it comes to separating babies from their families on everyone involved.
I'm going to jump in first with sort of the big picture from the research and
Wait,
then let let Julie and Kalie speak to the specifics because I think that's just so important to hear those things. But I think like one of the things that surprises a lot of people, right, is that when states have a policy that penalizes prenatal drug use of any kind, right? So prescribed medications or illegal drugs, any way that they're doing this, those states see worse pregnancy and birth outcomes. They see lower birth weights. They see younger gestational age, lower APGAR scores, more stillbirth, like we see more infant mortality. We see more neonatal abstinence syndrome. So babies born in states that are penalizing women for taking substances during pregnancy, those babies, when they're born, are more likely to experience withdrawal symptoms. And moms are less likely to engage with prenatal care, right? We also see higher risk of overdose to the mom We see more mental health issues for her. We see lower rates of engagement with treatment and lower rates of like lower interest or motivation for treatment. So I think a lot of people want to adopt these policies that they think will deter women from using substances during pregnancy. And what we see when we look at the population level and we look at these really robust studies that have tried to understand the impact of these policies, what we see is that those policies actually harm the mom, they harm the fetus, and they harm the child later on.
Yeah, Stacey stole a lot of those words straight from my mouth about, states that have more punitive laws tend to have worse outcomes for mom and baby and families. I'll say, when you have a child removed from a home, we have higher rates of postpartum mood and anxiety disorders. We have more short interval pregnancies, so women are getting pregnant more quickly, which can be hard on their body if you get pregnant within that first year postpartum. When a baby doesn't come home with mom, we're not having it interrupts the breastfeeding relationship. So that can be really hard to restart if and when the baby is returned to mom. Um, and we're not gonna have time to talk about breastfeeding, but breastfeeding is safe and appropriate. If a woman is taking Suboxone or methadone, it is recommended. It is helpful for symptoms of withdrawal for baby. Skin to skin contact is fantastic, as long as there aren't any comorbidities that would exclude a woman from breastfeeding. So when you interrupt that relationship within that first week or two and baby doesn't come home with mom, that can be really harmful for mom and baby. And when a lot of states have punitive laws saying, mom's still using, but then there aren't treatment options for mom. A lot of residential programs either don't accept pregnant women or they don't accept pregnant women after, a certain amount of time in pregnancy, like 24 weeks pregnant. Some providers don't, and as Julie said, psychiatrists don't want to prescribe mental health medications. Some substance use providers don't understand that, their dose of medication may need to increase during pregnancy to maintain that stability because of changes in the metabolism for mom. So when the barriers are too high to access treatment, yet you're being punished for not accessing treatment, you're just leaving women just drowning by themselves without any help or support, but expecting them to overcome this chronic brain condition all on their own through sheer willpower. So we need more low barrier treatment options, lower wait lists, and more childcare options. Luckily, in Richmond, we have a fantastic program where women can go inpatient for residential substance use care and bring their children up to 11 years old, and that they have on-site childcare. They're bringing school-age kids to school every morning so that mom can focus on her health and well-being and substance use. But that's one program, and that's the only one in Richmond, or excuse me, the only one in Virginia I know like that. I know of other ones that do accept pregnant women or children under the age of 1, but this is the only one that I've known that allows women to bring more than one child. So when we reduce the barriers, more women get treatment.
Yeah, so the two of you have covered almost everything I had to say, but I want to piggyback off of what you were just saying about housing because there are some real barriers within this area in far Southwest Virginia. And unfortunately, recovery facilities or housing facilities is one of those. Like we know Roanoke has a wonderful facility. It has about 15 beds, but that is the closest, and that's a 3-hour drive. So it's my long-term goal to see not just prenatal, but postnatal housing, something that they can transition from one to the other with their child and be able to stay there for a good amount of time while they go through recovery and try to heal their bodies and their minds and get themselves back on their feet again. But we have a lot of other issues here with transportation and like we are in a perinatal desert. So 45 minutes one way to get to a OBGYN, if a lot of them are sent across state lines. So that's a good hour and a half one way just to go see a doctor. Um, and there's just not enough resources. There's not enough funding for resources here. I myself transport participants to and from our site, and it's a good 3 hour drive and sometimes more, to get them to and from, and that's one way. Um, just we need more individuals that are willing to help and in this area, and to build more organizations that can help address these issues.
I just wanted to pull from the Q&A, Catherine Haynes, I'll just read it. She says, I wanted to clarify mandatory reporting is not required in Virginia unless a medical determination is made that the child is affected by the exposure. And I've been learning a lot about, well, who gets to decide affected by. But she says, I just wanted to make sure that is clear. I know people are reporting, but they shouldn't be if the medical determination was not made. So is there a gap there between technical words on paper and what people are doing in practice? I mean, Catherine is noting that your story about the placenta testing is just heartbreaking because if the child was not affected, there was no medical determination. Catherine saying CPS should not have been called. So is that the case? And is there a gap between what is written in policy and what folks are doing out there?
I think there absolutely is a gap, completely. And the wording, like you're saying, maybe they're taking it to one extreme when it was meant to be in another totally different way. Um, the policies that we've discussed earlier would be a wonderful way to roll that back and try to, help implement change in this area. It's definitely needed, and there's so many situations and stories that I could tell. I could go on and on forever, but they're all very heartbreaking. And it's time we do something. We got to do something to help these mamas.
And different healthcare facilities are going to have their own internal policies about reporting based on their, lawyers and risk. And also who's getting tested is also, determined by the providers that are on hand. So you see if hospital systems don't have clear guidance on who's getting drug tested and who isn't, you see a lot of implicit bias on, nurses and doctors determining who raises that suspicion of are they using substances. So there obviously can be a lot of like implicit bias and racism in that as well.
Hmm. Yeah, these stories, it just so often sounds to me like in the rush to want to punish, we have that instinct, I guess, many of us, um, making everything a little or a lot more unsafe for everybody involved. But there's just that urge, it seems like, to punish folks that are already in a really hard situation and often trying or wanting to be well and do well by their families. Just to revisit, I mean, I know we've talked about this, but would love to hear from Stacey and from you, Kalie and Julie. I know we at our street tend to be super pragmatic. Like, are there achievable changes that you think in the near term in Virginia that things that could really genuinely might be able to change to provide better tools or better guardrails or improve the situation, so that we don't have quite so many moms not being able to access evidence-based treatment, including medication, not feeling trusting enough of the system to engage with it and get the care that is best for them and their developing fetus. What do we think is achievable?
I mean, I can
Or
start
hope.
with yeah, like hopeful, achievable first steps, right? Would be sort of clarifying some of what came up in terms of making it clear that taking a medication that's been prescribed doesn't constitute a reason to suspect abuse or neglect, doesn't constitute that reason to report. And then I think I think Virginia has done some things to like actively try and encourage treatment early on and like provide those supports. But in addition, like one of the big concerns, right, is like, well, if there's no reporting, then women just being left to like they're not supported at all, right? And like thinking creatively about how do we build policy that simultaneously doesn't intentionally or unintentionally set people up to feel penalized or actually penalized, but then also maybe does a better job at keeping them connected, right? And like, how can we build something that actually promotes and supports that connection to healthcare providers, to systems like these potential housing programs, right? That are also recovery, that are also supportive of having a family and keeping your family together.
Yes, I would love to see it explicitly, the code changed, excluding medications, prescribed medications taken as prescribed. Because even if a baby has withdrawal symptoms from Suboxone, I don't think that that should be a reason to report if a provider does not have any other suspicions of abuse or neglect or concerns. I would love for Virginia to have dual reporting so we can fulfill our federal CAPTA requirements on reporting substance exposed infants, but then we can distinguish between something that rises to the level of needing CPS involvement and something that is just part of our analytics and reporting for tracking purposes.
Anything else in our final 3 minutes? Yeah, Julie, please.
Yeah. So, well, in my very tiny area, a few things like both of you had wonderful things that could be achieved. But I think also another thing that could be really beneficial is peer support, in the area because we are lacking here tremendously. These are just small things, like maybe not legislatively, but things that can be implemented to make those changes. Um, help with transportation, more funding, and ability to be able to get individuals to and from these sites, and and maybe even things like, body worn cameras for these CPS workers to kind of keep them safe as well as families. Things like that that could be implemented pretty simply, um, but could be tremendously beneficial.
I would add on to like the peer support piece, Julie, is such, I think this is something that often gets overlooked sometimes as like a benefit. In part because it is a newer thing, but peer support is massively cost saving too. So like from the R Street perspective, right? Like this is something that lawmakers can look to as a way to not only benefit certain constituents, right? But then it's benefiting their whole community as well in this really like practical way.
Absolutely. And we're seeing more and more clinics, doctors, OBGYNs, all of them using peers within, like in places like Roanoke and further in Eastern Virginia. Unfortunately, it's not yet come all the way over to Southwest areas, but um, being able to implement and outsourcing peer services would be a tremendous help in so many different ways. I think that's like a huge first step. One thing that I am doing right now to try to help, like, get some information and education, because that's another thing, just educating people in general, is, I'm going in my spare time, place to place, whether it be OBGYNs or clinics, and implementing a very good perinatal harm reduction toolkit for those with substance use disorder. And it kind of gives them a little guidance as clinicians and, nursing staff, as well as ways to help their patients. So,
Yeah, Our hospital system has hired two peers recently. They're all throughout the hospital, and we get to borrow some of their time for our pregnant and postpartum patients as well, and it has had a huge impact.
Thank you all so much. We are at time, so I'm going to let you go back to your very important day jobs. But I just wanted to say how grateful we are for you being here. It's not every day, at least for me, that get to learn from people who are informed on the evidence and wise on how to apply it and pragmatic on what that looks like in the real world, all while being putting so much love and empathy into families who really deserve support and thoughtful care. So we just feel really lucky to that you said yes to coming and sharing your wisdom with us. And Stacey, of course, thank you for putting all of it into context in the big picture of the evidence out there and the research out there. We're very grateful to you.
Thank you.
Yeah, thanks all.
And we will make this recording available in the next couple days and post to our website and share it back out with attendees. And as always, please feel free to reach out to us, and we can make connections and would love to talk to anyone working on this issue. I always say it, I'll literally talk to anyone. So please feel free to reach out.
Same for me as well. One last thing, there was another question in the chat. Is there any way that we could answer that?
Yes, if folks are willing to stay on, I'll stay here. Would you
Mhm.
like me to read it?
Sure.
Could you talk about the difference you see with patients who take medication for opioid use disorder versus women who have to or opt to rely on other non-medication interventions for substance use? So, are there different outcomes for MOUD, medication for opioid use disorder, versus other recovery paths?
Mm, yeah. So absolutely. I don't know if I should go first or if you want to go, any of you want to go first,
Go
but
for it, Julie.
so, those that take the MAT treatment path, are able to have a lot more support and stability. Um, I think I said this before, it gives them, a new sense of self and, a sense of, just starting over. They're able to literally, mentally, physically, emotionally get to a stable place and then gradually working on themselves. And I've seen so many make it to, whether they're getting their GED or they later go on to college and they start to thrive. And well, I'm going to use myself here on that spectrum because I was in MAD treatment and here I am now. So I work helping people. And unfortunately, those that might take another path, we tend to see a lot more overdose, return to use. They don't have the support systems that is needed, and it's very unfortunate that a lot of times their own family members are kind of dropping off, and they've just had enough and they can't deal with it anymore. So when we do meet with them, um, a lot of times it might be within the harm reduction program. A lot of people are down on harm reduction and, they think it's just a needle exchange program, but it's a great opportunity for those that might be in active use and they start out there, but it's proven 70 to 80% that are in the harm reduction program later go into treatment. So it's a good source to open the door for them to be able to go into treatment eventually. I don't know if that answered properly, but
Yeah, I agree 100%. But also to say, some people can be successful without medications for opiate use disorder. Definitely seen that. And, I know this is an opiate use disorder, talk, but when we see things for like stimulant use disorder, cocaine use disorder, there aren't any FDA approved medications for stimulant use disorder. And we can see people struggling a lot with that, and how different it is for someone with an opiate use disorder. And we have all these wonderful medications that are safe, effective. And then when you have a stimulant use disorder and you don't have those medications, it's just a lot harder, and it needs a lot more like behavioral health interventions and counseling interventions that are very effective, but it takes more time and more, a lot more energy and can take a lot longer to kind of become effective. And when, we do have some medications that doctors are using off-label for stimulant use disorder, but they're not going to use those off-label during pregnancy. So it's just a lot harder with some other use disorders without having those medications.
Yeah, I couldn't
Right.
say anything better.
Yeah.
So I
Well, thank you for that, and thank you for making the time to get to all of our questions in the Q&A. And we had some folks share share some resources there, so I dropped them in the chat so people can peruse those. But again, we're just very grateful to y'all, and hope this isn't the last time we get to connect and learn from you, and hope to see more education and brighter days ahead for the folks that you serve in Virginia. We really appreciate you.